When I have a patient that doesn't have enough room for the canines, I look at the facial profile to determine if it's going to be an extraction or non-extraction case. If the profile is too full and the line from the chin to the lower lip is going ahead of the nose, I'm going to do it as a serial extraction case. I still believe in taking out 4 bicuspids in patients that are too full. But for a lot of the kids that have a pleasing profile that I don't want to change, or a profile that's flat that I want to enhance, then I make the room either with expanders or with what's called degainer. The degainer, I can make room up to 5-6 millimeters. Anything greater than that, I'm going to have to use an expander. Now the degainer, I find, doesn't give me that much palatal remodeling, but it does give me localized alveolar remodeling to gain space for teeth. So my variables are facial profile, arch form, space for teeth. And then based on that, I decide what we'll be doing. And in this case, we've got young Mia, who has no room for her cuspids, but she does have a tendency towards bidental incisor protrusion. So I'm converting that anterior crowding into posterior transverse development. I can't afford for the incisors to dump forward anymore because they're already proclined. Therefore, I'm going to be using a high torque bracket inverted. That way, I'm getting the division 3 coming back to division 1, and my coil spring will be very light so I don't procline the incisors. This is young Mia, and you can see she has a very nice profile, which we don't want to change. We don't want the incisors to flare forward, so she ends up with lip incompetency, nor do we want to excessively retract, so she loses that nice fullness. And remember, as women age, the nose and chin get bigger, but the mid-face tends to stop by 12. So we like to maintain that mid-face fullness so the face looks more pleasing as it ages. If we look at Mia's teeth, you can see where the canines are here and here. You can already see the ectopic positioning of the lateral incisors, and the decision is to regain space for those blocked out canines. So if we look at the x-rays, you can see that the adult canines coming through, no resorption on the deciduous canine. In this, there's already a zone 2, Erickson-Curol's research. So Erickson-Curol removed deciduous canines early. That's one thing I'll be recommending to her general dentist. But the second thing is we're going to regain some arch width and detorque the incisors using the degainer technique. So if we look at the lateral ceph, we see that Mia has a neutral vertical angle. So she's not a brachyfacial individual, nor does she have a long face. If we look at mandibular length, it's slightly increased. And if we look at the vertebrae, you can see she has plenty of mandibular growth remaining. So one of the reasons these upper incisors are so proclined is because the upper incisors are compensating for the increased mandibular length. So we're looking at a class 3 B mixed dentition case, not enough space for the upper canines, and can't afford to extract in the upper arch in a class 3 individual. So what we're tending to do at this age is to detorque the incisors and gain more space for the canines, develop the upper arch so that we're in a better position as her face matures to make some more decisions in the case. What I like to do when I discuss the degainer concept is use a typodont as well as this Dolphin video. As I said, Dolphin through their aquarium software has really fantastic 3D imaging, and you can explain it very well to parents that way. So what we're seeing here is similar dentition to Mia, 4 in adult incisors, 2 adult molars, the rest deciduous teeth. And we're using a coil spring which is very light, and the light coil spring is giving us arch width rather than pure proclination. You will get some proclination, but we limit that by doing 2 things. Number 1, we use a lighter coil we only activate one bracket width of that coil. Number two, we use inverted brackets, which gives us negative torque. Number three, if we need to, as we go to the rectangular wires, we can use the reverse torque rectangular wires and place them in an inverted position. What does that mean? The wires that have torque built in, normally 20 degrees, if we place that wire inverted, we now have minus 20 degrees. So three ways to prevent your incisors from dumping forward is light night-eye coil, don't activate it too much, use negative torque brackets to begin with, and if need be, use negative torque in your arch wire. So let's talk a little bit now about bracket positioning. In 2x4, I don't use indirect bonding. I just find it's too cumbersome for 4 brackets. What we do is put our molar tube based on vertical. High angle case, molar tube's going to go very occlusal. Low angle case, the molar tube's going to go more gingival. As far as the upper brackets are concerned, we measure the height of the central incisor, and we mark the long axis. I halve that distance and we put it in the midpoint. So traditional Larry Andrews teaching a FAA point. So here is the typodont, and a couple of things you'll learn about degainer in my lectures. Number one, you have a long span between a lateral and a 6. So many times on a light wire like this, an 014, that can come out as an emergency. To prevent those emergencies, you can put a band on the 6 and use a arch wire extender, which are available from AOA laboratories, or you can bond the deciduous tooth, which is the E. I normally bond it, say, with a beg bracket. That way that span is not as long, and we have 2 teeth to stabilise the back of the wire. Either of those techniques are good to limit problems with emergencies. So the coil we use is night-eye coil, and I use the medium force. The diameter in these coils varies. You can't use too wide a diameter on 014, again, because of emergencies. So I'd like to use the 020 diameter. The concept is to measure the distance from the molar tube to the lateral, then add 1 bracket width extra of coil. That's all the activation you need. To put my brackets accurately, because I'm doing it directly, I use a bracket height gauge. I like this brand because it's got a swivel head, which means if I am having to replace a bracket in the buccal segment, I can still place it with this access. So if we're working in the mouth here and I want to measure the right height for that bracket, then as a swivel head, I can place that on the edge of the tooth and know where to place the bracket. But really, you're going to see this in use anteriorly this morning by putting 4 brackets on, measuring the height of the central, halving it, selecting which of these gauges will accommodate, and in this case it might be 5 millimeters, and if that's the case, we would place our bracket in the mouth and use the 5 millimeter height gauge. And the benefit of this instrument, you can push hard and the bracket is not going to fly off the tooth. Also, you're able to position the correct vertical dimension. The only thing you've got to be careful of is the long axis. A little tip for you: if you look at the point of the most curvature, that would be normally the long axis of these incisors. Plus I look at the OPG radiograph. So long axis of the 4 front teeth, bracket height gauge to put the brackets in place, and high torque brackets inverted in this particular case. In a Div 2 case, I wouldn't invert the brackets. It would be, I want some more torque. In a neutral case, I might use normal torque. So these are the decisions that you'll make diagnostically. From a clinical perspective, your kit is the coil spring, the Damon arch form wire, copper nitride 014. I've tried this technique with non-Damon wires and it just doesn't work. So the secret is not so much the coil spring. I've had a lot of doctors ask me, can they do this technique with twin brackets and with O-rings? The answer is no, I've tried it. What tends to happen, you get binding, and as a result you get a lot of flaring of the incisors. So you do need a passive self-ligating bracket. You do need light nitride coil spring. You do need the Damon 014 copper nitride wire. So with that in mind, we're now going to move to the clinical situation and see the brackets actually being placed on young Mia. So I'd like to introduce you to young Mia. Say hi to the camera, Mia. Mia is our demonstration case for upper 2x4 degainer treatment. So maybe I'll ask Mia, do you know why you're here? What is it that you don't like about your teeth?
Well, I would like my teeth to be straight and not be so messy.
Okay, good. Yeah, give me a big smile. And I think that's second tooth on the right, isn't it? So in the x-ray, we saw those laterals fighting for space. When you see laterals with no room, you've got Buckley's chance of the canine. And when Con shows you in the mouth, you'll see that the upper canines are ectopically erupting. And what we're trying to do is gain space for those. But can I get you just to look that way? So if we look at Mia's profile, right, you've got a very nice profile, right? She's got nice fullness of her lips, nice nasolabial angle. The last thing I want to do is to flare the incisors forward to give her lip incompetency or retract the incisors to ruin that nice profile. So the benefit of degainer technology in a child of this age is enormous. You don't need to use plates like Shorts plates, which the child may lose. There's no compliance issues with this technique. It's a lot more comfortable for the tongue than an expander. So the benefit of this technique preserves oral volume, the tongue sits where it's supposed to sit, and it actually helps us develop the arch form. It's fixed in 24 hours a day. Young kids like coloured braces. Do you want colours on your braces? Or are you happy with...
I'm not sure.
Not sure, we'll give you the options. One of the things I do for kids, if they want colours, remember with the Damon system, we don't want the O-ring in touch with the wire. We close the Damon bracket, we put the O-ring around the tie wings, we then open the bracket, put the wire in and close the bracket. So the wire is actually behaving just like a passive self-ligating bracket, but the kid leaves with some colours. I find at this age group they like the colours. The older kids want to make it at least visible as possible. I had one child who actually wanted Damon clear 2x4. So each kid varies, but we offer them the choice. But the main thing here, it's a non-compliance technique, and any general practitioner should be able to do this provided the diagnosis has been made correctly as far as the talk, etc.
So we promised the teeth. We've washed and dried the teeth thoroughly, and we've kept them dry. Now I'm about to place some Ortho Solo onto the teeth. So about to place Ortho Solo onto the teeth. Make sure it's dry. And we'll be doing the bond up in segments, which you have to do in most cases because 2x4 patients are quite small and little, not enough room. Okay, so I'll get brackets. And I'll get the six first. This is going to be interesting to do this bond up. So close just a little bit. That's it, good. Okay, so just placing our Ortho Solo on the upper anteriors, and you'll notice that due to Derek, as Derek mentioned, the proclamation of the teeth, our bracket would normally be positioned like so. However, we're going to invert the bracket. These are high torque prescription, so we're going to get a high negative torque, thereby moving our root buckle before we move the crown of the tooth. We don't want any more tipping in this case. Okay, a little more bond. Okay, and we're using our depth gauge here, and we'll select it to. This is how we use them. So you select the distance you want. So in this case, I'll use 4.5. So I place that down the slot of the bracket, and then I manipulate it and move it until the tip of the gauge is touching the height of the incisor. Then I push gently against the buccal surface of the tooth and remove. Invert, so we're going to go this way. So it's in a rough position, then we get the gauge. That moves up to the, so we're parallel and the right height of the incisal edge. Okay, suction. Now, because we don't have enough room for the lateral bracket, we could always place it and then replace it. But that is a little bit of a waste of a diamond bracket. And a simpler way is to use either a half bracket or a beg bracket. Now, I'm going to place the beg bracket vertically, and you'll see as to why. So with the hook side facing down. Actually, no, that'll be too difficult for me to engage, so I will place it hook side facing up. And you'll see why in a minute. Because when I drop the pin in, I'm going to use this beg bracket in the traditional manner. But I'm going to place the bracket more distal to where I would ideally place a bracket in this tooth. And the reason being, we can always, once we've made the space, we can get to it. Good. And we'll get the light. That's fine, thank you. Okay, so let's get our under tie wire. All right, so with the, if we're going to place in coil, we'll be placing coil in Mia's case at the follow-up visit, the next visit, once these front anterior teeth have leveled and aligned, then we'll be able to under-tie these teeth and place some push coil. Now, just as a technique exercise, if we were hypothetically putting the push coil in Mia's case, we'll be putting it between the deciduous second molar and the second incisor, the lateral incisor. So what we do, we measure using a flexible ruler, which we section to make it easier for us to access to see. We've got 10, 20, 21 or 22 millimeters between the mesial of the 6 to the distal of the 2 brackets. So we want to extend to the distal one full bracket distance. So we'll be extending to exactly, so we'll be going from the mesial of the molar through to the distal of the mesial of the lateral, which will be 25 millimeters. So if we had 25 millimeter push coil there, that would be the ideal length to be achieving degainer mechanics. On the other side, if we measure from the same point, mesial of the deciduous second molar through to the mesial of the upper lateral. So we're going 10, 20, 26 millimeters on this side. But we won't be placing that today because we need these incisors to be leveled before we can start pushing coil, using coil. Because we want to tie those teeth as a unit, and that way the coil acts truly as it's supposed to in the degainer mechanics and displaces the teeth to the buccal. So for now, I'll be tying this in, and you'll get to see me engage a big bracket in its traditional method. And now the peg bracket that I'll be engaging is just here. And you'll see the peg bracket has a hook or a slot, which the wire then runs underneath. You can see the wire runs underneath the slot, and then I'll drop in a pin there to secure the wire in place, essentially creating a passive ligating system. This is the beg pin that we just drop in, and you can use pin benders if you've got them. The Tucker and the Matthews should be adequate. Make sure it's not sharp or poking anywhere, and then we cut our distal ends and we crimp our stops as well. We'll cut there and we'll cut this side. That's it. And Matthew's lined up. And last but not least, we crimp our stop. Good. Yeah, that was quite tough, that. There we go. Alrighty. Nothing sharp or poking anywhere, Mia. Just double check. Put your fingers in there. Nothing sharp or poking anywhere. Good. Excellent. Excellent.